Okay. Okay, so what I want to spend a lot of time today, between today and tomorrow, is talking about this region of the sella, the paracellular area, the cavernous sinus, and the temporal bone. The way to understand this region very well, if you can understand the internal carotid artery, each turn, where the turn is made, what's around it. If you can understand that, you can understand this whole region. You will be a master at it. And I'm going to invest a lot of time and effort with you to really cover this very well. If you can understand what's around this carotid artery at every turn, you are going to feel very comfortable about this whole region. This is important for all surgeons who do transsphenoidal surgery, tumors, vascular, aneurysms, across the board. It's important for everyone. Okay? So we're going to spend a lot of time on this just so that we are 100% comfortable. Now with the residents who have the laser pointer, once in a while, around the world, some poor chap does a transsphenoidal surgery and gets into the carotid artery. Okay? I want to know which part of this carotid artery would they get into. Whoever's got the pointer, show me where you are. Keep passing it around. I want to see multiple answers. Keep passing it around and point for me. Do you have a pointer? It's not showing? Oh, the question. Sorry. So once in a while, some guy is doing a transsphenoidal surgery for a pituitary tumor on some poor patient. Okay? And they, once in a while, I've heard about this, in every country it happens, they get gush of arterial blood like crazy. That means they got into the internal carotid artery. Where on the carotid artery did they enter? While they're inside, they're doing the transsphenoidal surgery. They're doing a transsphenoidal operation. Where in the carotid artery did that poor guy enter? I'm sorry? Okay. Cavernous sinus. Okay, that point right there. Okay, keep passing it. Very specifically, keep passing it around. Let me see. That cavernous sinus. Okay. Okay, I hope your hand doesn't shake this much when you're doing surgery. Alright? I'm going to have some major problems if that's the case, alright? Alright, let's keep passing around. I don't want to make people paranoid now with tremor now. I'm just making a joke once, alright? I don't want you to go crazy on me this morning here. I have some Minister of Health writing me a letter, you're being harsh about residents, Sardinia or something. Okay, let's go. Show me the point. Show me more. Keep passing around. Okay, right there. Okay, keep passing around. Nobody can refuse to do this. So it's right there. Apply nodal segment. Okay, keep passing it around. Alright, we'll move on here. We have a number of answers, all good. So essentially, what I want to cover with you is this region right here, okay? And we're going to cover this region in a lot of detail because you need to understand it for many reasons. So, as you know, sella, optic nerve, carotid artery. What is this nerve? Oculomotor, tentorial edge, okay? So this is the area of the cavernous sinus. This is the area of Meckel's cave with fifth nerve V1, V2, V3. In most of neurosurgical literature, the confusion is most people who are doing schwannomas of the fifth nerve talk about operating in the cavernous sinus. That's not in the cavernous sinus. But neurosurgical literature is full of this. Okay. So we're going to cover this area. I want you to be able to, by the end of this talk, be able to see through the sella and know what sits on the other side, okay? I want you to be able to define which, the fifth nerve with V3, V2, V1, the carotid artery, which part of the loop sits right here and touches the pituitary gland, okay? I want you to be able, if you can know that, by the end of these couple talks, I think you'll be very good. I want you to develop that X-ray view. Okay? We're going to spend some time on the cavernous sinus, okay? And we'll discuss all those in detail. So the first point I want to make is that the optic nerve sits above the carotid artery, okay? And the superior hypophyseal arteries come out of the carotid artery mesially and supply the pituitary gland, but also supply the bottom of the optic chiasm. Do not take these arteries lightly when you're doing a meningioma here. There are reports of people losing their vision after these surgeries. And people are surprised completely why that happened. That happened because some of the blood flow to the chiasm was obstructed. Okay? We're going to talk about the clinoidal region. And I'm going to show you one or two cases in which I open the dura like this. Then I'm going to reflect the dura back. Then we have the clinoid exposed. Then we're going to drill the clinoid. Drill, drill, drill. Then there is a small process here called the optic strut, which we have to break, to which the clinoid is attached to. You have to break it to remove the clinoid. Then we remove it. Below us is the superior orbital fissure. Right here is going to be, so we're going to be in the cavernous, at the inferior part of that opening, we're going to be at the level of the cavernous sinus. Okay? I want you to understand this anatomy very well. Okay? The carotid artery makes a loop here, so I'm going to talk to you about the lateral and the medial loops of the carotid. Those are going to be a lot more understandable than this numbering system that exists in the literature. Okay? The carotid artery here does not come straight like this and turns around and comes here. It comes like this, loops like this, and comes like this. So it's a figure of 8. So there's a loop of the carotid here, touching the sella. That's a medial loop, and this is a lateral loop. Now I'm going to refer to them as medial lateral loops, and we're writing a paper right now to reclassify the naming of the carotid artery that would be easier for clinicians to use and make more sense. As I go through this talk, you will see why this would be a lot easier system to understand. Okay? So we're going to understand this region in a lot of detail. The cavernous sinus, as you know, is the lateral wall of the cavernous sinus where you have 3, 4, and V1 and V2. The sixth nerve is very deep. It's touching the carotid artery. It does not sit on the surface. Okay? The sixth nerve is very deep. Okay? But we'll look at that. So if we look right through the sella to the contralateral side, what are we going to find? We're going to find in the back part of the sella is the Gasserian ganglia. You have V1, V2, and V3 going straight down. V1 is going right up to join in the superior orbital fissure, to join the nerve to go through the superior orbital fissure. Okay? V2 is going through here, through the maxillary, going to the pterygopalatine fossa. And V3, as you know, the mandibular nerve is going straight down. So on the other side of the sella are the neural structures that you have to be aware of. On the other side of the sella, the anterior part of the sella, you have the cavernous sinus. In the back part of the sella, you have the Meckel's cave, in which the fifth nerve ganglia sits. The Meckel's cave is nothing but a CSF-filled space. Okay? When you open it, it's full of CSF, just like any CSF compartment. Alright? So those are the things you have to know with your X-ray view, that's what exists. The medial loop of the carotid that will show you will come around here and touch the pituitary. Then lateral loop goes like this to come in intracranially. We'll show you that in a minute. And that's the medial loop, and that's the lateral loop, but we'll have much better pictures. If we look at the left side from the right side, okay, so we've cut sagittally the brain. This is anterior, this is posterior, this is superior, this is inferior. This is a carotid lateral loop. Anterior clinoid sits right here. Okay? The anterior clinoid sits right here. This is, do you see how laterally, like this, the carotid is going? This is a ophthalmic artery, this is the optic nerve. Okay? Look at the sella right here. The anterior part of the sella is the cavernous sinus. The back part is going to be where the Meckel's cave is. Okay? What is this nerve right here? I'm sorry? V2, maxillary nerve. Very good. This is a pterygopalatine fossa. This is a maxillary artery, which, as you know, some of you know, I have used this artery now for bypasses we're doing. We'll show you that later. Okay? So we're trying to create this relationship for you. Okay? So let's define. Now I'm going to interested in anybody memorizing any names. What I'm interested in for you to know relationships. The relationships are the most important thing to learning surgical anatomy. Names, all the triangles and stuff, I could care less. And the patient on the table could care less if you know all the names. Okay? What makes a difference for you to understand certain relationships. Throughout these 2 days, I'm going to give you a number of relationships I want you to remember, and they will always help you in kind of solving problems. The carotid artery that I'm talking to you about, I'm going to tell you, comes from a cervical area, makes a 90-degree turn anteriorly, and 45-degree turn medially. Okay? So 90 degrees anteriorly, 45 degrees anteriorly right here. That happens right in front of the cochlea. So this relationship where the carotid turns in front of the cochlea is a very important relationship to know. Okay? Then it has this ascending segment inside the cavernous sinus. Okay? This happens inside the cavernous sinus, and the fifth nerve, ganglia, sits right here. So the ganglia sits right here. And the ascending carotid in the cavernous sinus goes up here. This is the medial loop. This is a lateral loop I was showing you a minute ago around the clinoid. So medial loop, lateral loop. Then you go to, okay? So I'm going to show you a few relationships that are related to this, and hopefully by the end you will put a lot of this together. If we look inside the orbit, okay, and we're looking at the right orbit from the front, okay, optic canal, okay, this is a strut, the optic strut, okay. This is the superior orbital fissure. All the cranial nerves sit right here. Nothing sits out here. Okay? All the cranial nerves sit here. So the optic strut, this is the anterior clinoid process here. Okay? So for you to remove the anterior clinoid process, you have to cut the optic strut. Okay? That's important. Let's look from behind. This is lesser wing, spheno wing, greater wing. Superior orbital fissure. All the cranial nerves sit here, not here. I see people all the time spending all kinds of time dissecting around here, worrying that they're going to get in the nerves of superior orbital fissure. There's nothing there, all right? No reason to waste time up here. There's nothing. You don't have to worry about it. Everything is much more medial and deeper, right? That allows us a lot in skull-based surgery because I very quickly dissect all this dura all the way here because there's nothing here. There's nothing you have to worry about, okay? Then you have the clinoidal process that's attached to the optic strut, and that's the optic nerve. The cranial nerves from 3, 4, 6, V1, all go through here. Okay? The carotid artery, the lateral loop, is going to be coming up underneath us here, turning this way, and turning towards us right here. The lateral loop. And the medial loop is going to be here. Okay? So when we're drilling here, the carotid is below us, and the optic nerve is medial to us, and the cranial nerves of the cerebral fissure are below us. That means you're working in this triangle. The nerve that's closest to the optic strut, closest to the carotid, is the third nerve. So when you're drilling the anterior clinoid, and when you come deeper this way, it's the third nerve that you have to worry about the most. Let's look from anterior. Optic nerve. Anterior clinoid process, okay? Clinoid here. You see this is a lateral loop, projecting lateral, okay? This is a cell. These are the hypophyseal vessels, the medial hypophyseal vessels that not only supply the stalk, but also supply the chiasm. Important vessels. You know, sometimes we have hypophyseal aneurysms that sit here. I can show you some of these. And you have ophthalmic aneurysms that project superiorly like this. Okay? So hypophyseal aneurysm will be going like this. Ophthalmic aneurysm will be going like this. Alright? Okay. Closer up view. You see that lateral bend of the carotid. Hypophyseal vessels, chiasm, A1. Closer up view, looking at these hypophyseal vessels. Very important structure that you have to be careful about. More view of these vessels supplying the chiasm. So be careful. Especially important these vessels become when you're operating on a tuberculum cella meningioma, which is really embedded right in here, in this location. This is tuberculum cella meningioma sitting right there. Okay? Okay? So these vessels get very stretched thin. And you gotta be very careful that you're not bipolar in these things when you are operating on a tuberculum cell meningioma. This is a very inferior view looking from below. So let's try to put some of the things we talked about. This is ascending carotid artery. It is in front of the cochlea that will be here. It will turn 90 degrees anteriorly and 45 degrees medially. Okay? Then it is this segment, which is the ascending segment in the cavernous sinus, which sits right next to the fifth nerve, which is going to be sitting right there. This is a medial loop that touches the pituitary, and this is a lateral loop. Okay? So this is anatomy that we want you to get, So, once again, ascending carotid, cochlea, 90 degrees anteriorly, 45 degrees medially. Ascending cavernous carotid. That means the fifth nerve is going to be right here. Medial loop touching the pituitary. Lateral loop below the clavicule. Okay? It is right here that touches the pituitary where people can get into the carotid artery, obviously, during pituitary surgery. Okay, our standard surgery, a lot of things we're going to be showing you is going to be coming like this. Optic nerve, carotid artery. The third nerve, before it enters the cavernous sinus, there's about 5-6 millimeters. It has what we call the oculomotor cistern, meaning it's not in the cavernous sinus, and this little space allows us to open this dura here just to give us one extra space. Okay? So it does allow you to open the dura before you get into the cavernous sinus. You see all of this? It's all in the cistern. It's not in the cavernous sinus. Now, tumors that arise in the cella and supracellular tumors behave in a certain way. And I'll give you some of my own personal impressions about these. Anyway, this is a standard pituitary tumor that you do transsphenoidally. Tumors that arise from the cella, okay, or supracellular, and push up, if the optic nerves are long, meaning it is a post-fixed chiasm, have more space for the tumor to get between the optic nerves and go up. Okay? Whereas people who have prefixed chiasm, where the chiasm bed is short, and the whole tumor is pushing on the chiasm, I believe these patients present earlier than these patients from my observation. Because here there's not much space. The minute the tumor starts growing, they start having visual deficits, whereas these tumors can get somewhat bigger. So smaller tumors here will present clinically versus larger tumors here. Okay? That is a generalization, my observation, not published, but this is my feeling about it from a number of cases. Okay? But it does have anatomic and surgical implications, which we'll show you in a minute. So these tumors that stay below the chiasm, we call them retrochiasmatic locations, because they stay below the chiasm. It makes it very difficult from above, through a subfrontal approach, to get into these tumors. Whereas on these tumors, it's very nice because you're working between the two optic nerves. So the trajectory to a tumor like this is more lateral versus a tumor like this where you can come in between the two optic nerves. So a number of relationships I just described to you, relation of the optic chiasm to the tumor itself. So that's, for example, looking from above. So with this we call the planum, okay, sphenoidally. In this area we call the tuberculum, okay, tuberculum sella. So the meningioma occurs here. We say a planum tumor. This is a tuberculum sella meningioma, okay. Let's start with a few questions. So this patient up here was sent to me because the patient was having headaches and had gotten an MRI, and the doctor, the neurologist, sent him to me for a lesion. Can you tell me what is wrong with this MRI? This is T1 with no contrast. This is T1 with contrast. So the top patient. Where is that name list, Dr. Ahmad? Where's the list of all the residents? Oh, you have it? Oh, you should have told us in the morning.
We have lists.
We've been struggling all day. Are you hiding the list?
لو وين وصلت هي؟
يا وين وصلت؟
Oh, it's not. Oh, I see. It's going to take a couple days to get all the way up there. All right. Essentially, I need volunteers. Tell me what's wrong with that patient. Okay, this is for all neurosurgeons now. Everyone will see us pituitary tumors all the time. So I want you to tell me T1 no contrast, T2 with contrast. What is wrong with this? What is the diagnosis? What's the lesion? What's the surgery? needed. What is the problem?
Pituitary macroadenomas.
Okay? Let me stick with the residents first. All right. So, okay, so what's the lesion here? Tumor in the pituitary. Show me, give him a laser pointer, please. Where is the laser pointer? Please show it to Adam. We have a Canadian Saudi here. I don't know how these guys are born in foreign countries. All kind of. All right, give him the. Are you considered a real guy from here? All right, show me that. Show me the tool.
Okay, so this is T1 without contrast.
Right.
With contrast. You can see that this area is taking up contrast
Right.
after administration of gadolinium. So I believe that this is the area of the tumor.
Okay. What is?
It's in comparison. I mean,
Yeah.
I'm comparing the
Those are the same patient.
same patient.
T1 and T1 with contrast.
Without and with, I can see that this area is taking up contrast.
Okay. Other senior residents, they agree, disagree. Is there everybody agrees with the diagnosis? They're not here. Oh, he's saying this is a tumor right here where most of the enhancement is. Is that correct?
No. No, I have one comment. The T1 is like normal pituitary, and the normal enhancing pituitary gland.
Okay, very good. What I want you to recognize what a normal pituitary looks like. This is a completely normal pituitary gland, all right? So what this is that in a normal pituitary, the posterior pituitary, this is a bright spot of the posterior pituitary on T1, okay? This should be normally present in every patient, all right? So this is a bright spot that you should see in every patient with no contrast. This is a normal size pituitary. When you give contrast to a pituitary gland, it should uniformly enhance. The stalk should enhance. The stalk enhances in kind of a wider up here at the tuberous area and thinner here. So this is a normal pituitary. No one should operate on this patient. Unfortunately, throughout the world, people are getting surgeries for pituitary tumors that do not exist. Okay? And so you need to understand, the neurologist sent me this patient. So, so you got to be you are the surgeon who's going to operate. You got to understand this very well so you know what's normal before you decide what's abnormal. Okay? So after 6 weeks of age, every human being will have a posterior pituitary bright spot on non-contrast imaging. Okay? And then, if you give contrast to a pituitary gland, the pituitary gland enhances. Just as well does the stalk. Now, pathology starts when you start seeing enhancement at the floor of the third ventricle. That should not be there, right? The pituitary should uniformly enhance, not one big area right here and no enhancement here. That's abnormal, okay? This is the same thing here. This is the same patient in T2. Normal T2. Wider, thinner here. This enhancement of an axial, the enhancement is always more in the midline of the pituitary than it is lateral. So when you see an axial of a normal patient, more enhancement should be seen in the middle of the pituitary than laterally. Okay? And this is a coronal view. This is the size of the normal pituitary gland. Okay? That's the size. It's usually less than about 7 millimeters or so. So I want you to entrench this view in your mind. Okay? Because a lot of neurologists and radiologists will fool you, will send you a patient who's having some symptoms and suddenly he apparently has a pituitary tumor, he or she. You have to be very cognizant to these findings before you decide to operate on somebody. Okay, so I'm going to just... at birth it's very globular. At 6 weeks you have the normal appearance of the posterior pituitary. So see, at birth you will not see the bright spot. So if somebody shows you a 2-week-old child with no bright spot, don't go crazy, okay? It's only after 6 weeks you should have the bright spot, okay? Okay. So these are the structures we're talking about. This is the tuber cinereum, then you have the stalk, the mammillary body is going to be behind it. This should not enhance. This should not enhance. Only the stalk, okay? And the pituitary, uniform enhancement. That's normal. So when you're looking at the cella, it's a complex region. I want you to have a diagnostic approach. When you see a lesion in the cella, I want you to have a systematic way of looking at it. Not haphazard, well, I'm seeing this. I want you to look, as I said, first thing is stand back. Don't jump into something. Find the pituitary inside. Localize the epicenter of the lesion. Analyze features. Cystic, is it solid, is it bone? Consider the age. The age is going to make a difference, as I'll tell you in a minute. Generate the differential diagnosis. Okay? So you got to find out the pituitary. If the lesion is here, you know where the epicenter is. If the lesion is here or here, you got to know where it is. Consider all these things. Look at the stalk. Is the stalk the normal, very mild V-shape? Is it enhancing uniformly? Or is the stalk bulbous, round like this, which looks like a tumor? Right? Next, I want you to look at the chiasm. Don't be fooled thinking that it's a pituitary tumor when it can be a chiasmatic tumor that'll be going like this. I'll show you a case I had like that. So look at the chiasm and see if the lesion is rising from the chiasm itself rather than from the pituitary gland. Okay? And consider all these things for everything I'm telling you. Look at the hypothalamus. Sometimes a hypothalamic tumor, will grow into the chiasm, will grow down to the cell. Don't forget, then you're not dealing with some benign pathology down here, but you're dealing with an aggressive glioma of the hypothalamus that may not need aggressive surgical intervention. Okay, it may need a different type of treatment, and so you got to be careful about that kind of thing. Next, look at the vessels. It could be an aneurysm sitting right here that you think is a pituitary tumor that you're going to do a transfemoral operation on. Unfortunately, has happened and continues to happen around the world. Okay. Look, if it's an aneurysm, what feature did it have an MRI? Does it have a flow void? If it has a flow void of any kind, you are not touching that patient until you do an angiogram. Okay? You are not going to go take that patient to the OR to do a transfemoral surgery. If the thought crossed your mind that this could be, it's rounded, I'm not sure what it is, you are not doing a transfemoral operation until you have seen the angiogram yourself with your own eyes. Because you can kill that patient. Okay? So that's a very important obligation for you. Look at the cavernous sinus. The lesion may be a cavernous sinus lesion rather than a cellular lesion. Okay? Look at the cavernous sinus. Is it a large cavernous sinus? Is one cavernous sinus like this? The other is like this, meaning there's something in the cavernous sinus. Okay? There are meningiomas in the cavernous sinus. There are schwannomas. There's angiomas. So there are all types of things that can happen in the cavernous sinus. So look at that. And, again, if it's a cavernous sinus lesion purely, you really do not want to be going transsphenoidally, endoscopically. You're asking for trouble unless you're very, very experienced at doing that kind of thing. Look at the wall of the cavernous sinus. Is it rising outside the wall in the temporal lobe, or is it rising out here, inside the cavernous sinus? Okay? Look at the sphenoid sinus. Is this a carcinoma, an nasopharyngeal carcinoma that's invading through this and going up to the brain? Very important to look at the bony anatomy and make sure it's not a lesion sitting, a cancer that's going up the other way. So that you need to know front. Because that simply can be biopsied by EMT simply, and you don't need to be doing any neurosurgical procedures. Okay? So those are the things I want you to think about as you look at these patients. Alright? So, let me tell you, this is the first patient that was sent to me. Okay? And this is a 15-year-old girl who was having headaches and passed out once, and she had disc coronal MRI with T1 right here. Okay, this one patient. This gland, this is clearly big. What do you think is going on? What is the disease process here, and what do we need to do? This is not the normal pituitary I showed you earlier. Okay, this is not that situation. What is wrong with this patient? I'm sorry? Speak up. Thinking loud. All right, that's okay. Listen, there is nobody grading anybody here. I'd much rather you make mistakes here than to make them in the operating room. When I was at your stage, I would not be able to answer most of these questions. It's much better for you to really openly, this is your time to discuss this. Don't worry about making mistakes. Nobody's grading anybody here, okay? I didn't know most of this stuff when I was graduate, so I'm not in any way holding you at a separate standard than my own, okay? So what do you think is wrong here?
So are the whole cuts for the same patient?
No. These are different patients, I'm sorry. I'm just showing you that one slide. I'm sorry? Empty cellar? No, it's not an empty cellar, although it's a good thought, and I'll show you empty cellar. This is filling the whole cellar, this thing. This is not CSF. It's a contrasted, that's gadolinium, and it's the whole thing. So it's not, yeah, you always have to think about empty cellar. It's a good thought. Always have that in differential. What do you think is going on here? I'm sorry? Flow void? No, I don't see a flow void here. This is actually, always think about a flow void, but remember, this is your chiasm here, this is a stalk, this is the lesion, those are just normal CSF space here, no large flow void here that I can see. Okay? Is she pregnant? She's not pregnant. She's 15-year-old.
The stock is compressed and deviated.
There is no deviation, it's symmetric. It can look like it, you look at it from far away. There's no deviation. Good thought. Always look for deviation. Very good. So what's the problem with the 15-year-old and what is the next step?
Is it hypertrophy of the pituitary gland? Hypertrophy of the pituitary
Very good. Okay. 15-year-old girls, at the age between 13 to 16, will normally enlarge that pituitary gland beyond what is normal. Okay? I have been sent a number of girls to operate on their pituitary gland in this age group. Do not touch these patients. Okay? Radiologists and neurologists will get this wrong all the time. So peripartum women, okay, in pregnancy, somebody was mentioning that late in pregnancy will have enlarged pituitary. The other age group is this. You say thank you to her and her family, everything is okay, I'm going to bring you back. Just at the same time, you have to be careful. You see, it's an enlarged pituitary by about 4 or 5, you see how it's bulging the diaphragm out. You see, you know what? 9 months from now, I want to get another MRI, just to see when you're about a year older. And that's her MR 1 year later right there, next to her. Normal size pituitary. You don't touch the patient, but you follow up. Once that large pituitary was some abnormality, and you missed it, you said it was, so always be on the safe side. First of all, you never operate with that patient in that age group with a diffusely enlarged pituitary. But you are obliged to obtain one more MR, just to document that the pituitary went back to normal size. So 2 things. You are recognizing, you're telling the family, assuring them it's normal, don't worry. Same time, you want to know that that 1% chance didn't miss something, and the patient had something, and she happened to be 15 years old, okay? So, safety, conservatism in thinking, but follow. That's the line of thought you have to have. Unfortunately, many girls in this age group have had surgery that have been sent to because of this finding. And I want you to be educated about this, and it's unfortunate that this happens. Happens all over the world. Unfortunately, because what? Neurosurgeons are not deeply educated about this. It's not their fault. It is this kind of stuff that I've seen over the years that had led me to create this curriculum. The guys who are seeing this every day should be making that decision. A guy who's seeing 3 pituitaries a year to look at this and say, why? There's a tumor there, the radiologist is reading it, I'm going to operate. Okay? That's the difference. This is why we need to start thinking from this group practice mentality, and people who see this day in, day out, every day, is different than somebody who doesn't see it all the time. Okay? So that's important. Okay. This is the second patient here, this right here. This patient presented with acute headache and visual problems. What is the problem? What's your differential diagnosis? Number 1. I'm sorry? Intrahemorrhage, apoplexy. 1, okay. Another thing? Craniopharyngioma. Yeah. Anything else? Glioma could be it. Yeah, that's very good. Actually, this turned out to be a giant aneurysm, okay? I'm showing it to you just to make sure. Do not forget about the danger things, okay? This is one of my patients that was presented to me. This was a massive giant aneurysm. Always think about everything. Calcification of the periphery happens in aneurysms. Round structure happens in aneurysms. Most likely, if you were given 100 cases like this, it's going to be craniopharyngioma or pituitary tumor. I agree, no problem. But I don't want you to forget those things that can get you a lot of trouble, and you will hurt some patient, okay? How about this other patient next to me right here? What is the most likely diagnosis? Craniopharyngioma. This was a craniopharyngioma. Very good. This is an infundibular tumor that we followed for some time and continue to follow. He's presenting with DI, which got better. This is not normal stalk that I showed you before. So I'm following this patient very closely. I've not operated on it because he's totally fine, totally functional, had a transient DI, and now no longer has a DI. So every year I get an MRI. It stays the same size, I'm not going to mess with it. Okay? There is no reason to go in and try to mess with this guy. Alright? Now if this gets bigger, one, or he develops new symptoms, two, he will buy an operation. Okay? For us to biopsy. But as long as it stays, we're coming to time. Okay, so we're going to stop this session here because we want to take some time for questions. Is that okay? So we're going to stop here, but we'll continue this session after lunch. Please go ahead. Anybody who has questions, this is a place to ask freely. There is no stupid questions. I want you to feel comfortable, that you understand. We're going to spend a lot more time on that carotid and that paracellular area. We haven't even touched that yet, so don't worry about that. I mean, we just touched the very, so I don't expect you to know all that. I'm just giving you a little brief thing on it before we get into it more detail. But besides that, is there any questions about anything we discussed so far? Dr. Maher.
I have.
Yes, sir.
There is some trick in the first case. Sometime a young girl, she can come with a high prolactin.
Yeah.
Because of the pressure of the stomach and high prolactin.
Yeah, I think if there is an elevated prolactin, you've got to take that case very seriously because those patients I've seen with enlarged pituitary glands, none of them had an increased prolactin level. If they have increased prolactin, I've got to have a high level of suspicion something else is going on. I'm not going to just say, oh, this is normal variation. No, if there is an increased prolactin, you got to believe there's something going on. Either within it there's a tiny microadenoma that's producing prolactin or something. I'm not going to just say, well, no, this is normal variation. No, I agree. That's a very good point. If there's an abnormality, where the growth hormone is elevated, LH is elevated, prolactin is elevated, there's something going on. We are not going to say that's a normal just increase. Yes, there's a question back there, sir.
Yeah, my question regarding your technique in AVM surgery. It's nice, beautiful way of dissecting the aneurysm from the nearby structure, parenchymal adjacent structure. But my question is, your way of holding the draining vein for 30 seconds. I mean, how would you differentiate? This is an important draining vein or just a small vein? Is it enough just to hold it for 30 seconds if there is no edema? I mean, is it safer to take it as a vein or just keep taking the feeders on there?
Yeah. That's a good question. I hold that, like so, at the end of the case, when I've taken all arteries and veins, I will hold the last vein, the last draining vein, before I officially take it, just to make sure I didn't miss a feeder or something like that. But earlier on in the operation, as long as I have one big vein, the major vein open, I'm very liberal about taking other veins. It never is an issue, because when you have the key draining vein still open, I take veins I'm not doing that technique, I'm very routinely just moving, you know. It's the last vein, when I've taken all the feeders, now I'm down to the last vein, just to be sure, I will hold it, especially if it's a deeper AVM. On the surface, it really doesn't matter, but deeper, I'll hold the vein, make sure there's no bleeding coming, nothing happening, that I missed some feeders, 30 seconds, whatever, then I'll take it. It's just an added precaution, I guess. The other thing you could do, and people have done, is put a temporary clip on for 30 seconds or 2 minutes, and then remove the temporary. Whatever makes you feel comfortable. It's just whatever technique that makes you more comfortable, that's fine. Yes, sir?
Regarding the last case, the fundibular tumor.
Yeah.
I mean, was it once touched to be fundiglioma, acting like tectum glioma, which is nobody touches now?
Yeah. So these tiny tumors in the fundibulum, in the stalk, sometimes can be very benign lesions, very similar to those osteotectal tumors. The idea for me in neurosurgery, conservative thinking overweighs everything else. There are very few patients that you should see in clinic and rush to surgery the next day or next week. I cannot even imagine what case that would be unless somebody is losing vision, something acute neurological deficit. It does not hurt. Every tumor case I've seen, I always say, If they're not acutely losing neurological function, let me see you back in 3 months with a repeat MRI. I want to see if this is a growing tumor or not. There is no rush to operate on these things, okay? I mean, in general, there's no emergency here. I think there is this mentality in the 50s and 60s in neurosurgery, like you put the x-ray up, okay, there's a lesion, let's operate. I think we're moving towards more conservative thinking and judgment, like, okay, when you operate on a patient in their brain, you got to have a clear-cut mandate to operate. Not, well, maybe I should have or should not have. Imagine a case where you operated, somebody had a bad outcome, where you said to yourself, well, friend, maybe we should have operated, maybe we shouldn't. You should never find yourself in this situation. You do a case for a good reason, and if you had a bad outcome, at least you know you did the right indication for the surgery. You never want to be in this gray zone and then have a bad outcome. So anything infundibular, or all these pituitary tiny microadenomas that are not causing huge hormonal things, I never operate on them unless they're pushing on the calves. I'm going to watch them. I have patients now for months and years I've been watching, never operate on, with pituitary adenomas that are not doing anything. There's no reason to do surgery. Why? I mean, there's nothing, Now, there are things, if somebody has a growth hormone producing pituitary tumor, that's a dangerous lesion because that affects their liver, their heart, everything else. Now, that changes your perspective, right? So aggressiveness depends on the natural history of the disease. And you're going to make a decision based on that. Yes?
If you have a small meningioma, 2-3 centimeters on the motor cortex, on the left side.
Yeah.
In a postmenopausal woman, presenting just with seizure which is controlled by simple drug.
Yeah.
Do you operate?
Is she symptomatic from the meningioma?
Just seizure?
Just seizure? No.
And
Seizure is not going to necessarily be cured by surgery. If she's asymptomatic, it's on her motor strip, I'll follow it. If the tumor grows, which tells me that there may be a bad tumor, or she starts having any symptom while I'm having a little, then I'll operate on it. But if a tiny tumor is sitting on the motor strip, there's no reason to go mess with it. No reason in the world. Yes?
In cortical AVMs,
Yes?
any role for pre-op embolization?
Yeah, I think in larger AVMs, there is role for peripheral embolization. Remember, embolization is done to make the surgery easier. It's not done to do embolization. This is where the biggest mistake happens. See, the difficult things for us are the deep feeders that come from below, that's behind the field. So if you got a huge MCA feeder, huge ACA feeder, well, that's the first thing you're going to see when you get there. Take seconds to take them. Why are you going to put the patient through a huge catheter and embolization? No way in the world you need that. Now, these feeders, these AVMs that are bigger, that they're feeders from underneath that are big, that are going to be deep to you. That's what you want to take. The problem with a lot of the embolization neuroradiologists, what happens, they take the feeders that are easy for you to take. Well, what's the advantage? I could have taken it in seconds, right? And what's worse than that is this stage treatment that goes on in many centers. They embolize, then radiosurgery. I'll show you a number of cases. These are the disaster cases that bleed later that make it very difficult for us to operate. AVMs is like being pregnant. You're either pregnant or not, okay? Messing around with AVMs is crazy business. And I will show you why, in cases, why this is such a big mistake. If you're going to try to treat an AVM, you're trying to cure it. Otherwise, leave it the heck alone. So some centers, I get cases where they embolize, well, it's a big AVM, let's embolize part of it. And a year later, let's embolize another part. Then they send it to radiosurgery. The patient's still not cured. You know what happened now? Now, the AVM that was simple to resect has become a very difficult high-risk AVM for me to resect. Okay? Why? Because the big feeders, when they're taken, they recruit deep, difficult feeders from difficult vessels. So now this becomes surgically a very complex case when we could have resected it when we first saw it. So I tell always, AVM should be very deliberative treatment. If you tell the patient you're going to treat, you are treating for cure. Except obviously in deep-seated AVMs in the thalamus and the brainstem, or tiny deep AVMs where you should give radiosurgery to, because the risk of surgery is too high, right? And you don't want to leave them alone because tiny AVMs are very cured by radiosurgery. So even though it's not cured up front, it takes 2 years, it's worth it. But beyond these two scenarios, putzing around with AVMs and partial treatment is a big mistake, and it should not be done. It should not be done across the board. Yes, sir.
Back to the pituitary part, you mentioned that if the patient is coming with a focal deficit or visual disturbance, you will operate. But if it's only hormonal, this is what I understand, that you will not operate on the patient unless it's GH.
No. So if there's a hormonal disturbance and somebody, let's say, has a very, let's divide it. So if it's very high prolactin, we will treat medically. Obviously, there's no surgical treatment for that, right? For growth hormone, I'm going to be very aggressive about resecting that lesion, because growth hormone, if they have elevated growth hormone, that affects systemically. So I'm going to be very aggressive about resecting that lesion. So it depends what kind of hormone disease we're dealing with. Each one is treated differently, even though it's not touching the chiasm. If it's not treated, it's not a prolactinoma, then if it's something else, then I think you're going to have to, you're obliged to treat.
Yeah, but if the patient comes like with a bleeding, apoplexy, and I decided to treat the patient conservatively. Later on, would I go to resect that tumor? Or?
By apoplexy, you meaning they had no visual disturbance?
No.
Okay, so there was hemorrhage in the gland.
Hemorrhage, but no.
Yeah. I mean, that clearly means that there was a tumor there inside. Okay? In very rare cases, you can have ischemia of the gland that can cause bleeding. That's extremely rare. But you're going to have to restudy that patient once the bleeding occurred, or at least to see where the lesion, you're going to have to go treat it, because any lesion that has bled can bled the next time and cause visual deficit. That patient's going to need treatment, for sure. You can, yeah.
I think we have to stop.
Okay.
Thank you very much for wonderful sessions.